Assalamu alaikum, Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Uh, we are living in a country where tuberculosis has always been a problem. And as a clinicians, you know well that only statistics changes, your enlisting in the high burden countries changes, otherwise problem remains the same. And you must have seen during previous few years that when we showed that the number of tuberculosis patients are reducing, then actually there was a warning letter that kindly review your statistics and resubmit it. So that's how alarming our part of the world is. I'm sorry, slightly yesterday's weather is affecting my throat. So this is one disease. When you think of a patient who is suffering from two diseases, how he will be managing those diseases? One is HIV and one is tuberculosis, and that's a double-edged sword for that particular patient. So as a physician, as a clinician, I think we all are concerned and we will feel pity for that patient. So that was the thing which really was a motivating point to look into that what actually is happening in HIV TB co-infection in our area. So you know well that in Pakistan there was few centers who were reporting HIV cases. Few centers were slightly before 2016, they were not that much collecting the data, but mortality was the main concern among those people. 1.8 among 636 HIV positive cases were postulated, and the mortality was 0.6 over 100,000. Now, this mortality is important. Reason being that HIV patients, they not only results in high mortality, but also they affect your conventional treatment, because the antiviral therapy which you give and HIV itself, it can pose a problem with your first 4 drugs, and then alternatives are considered and further problems happen. In certain studies, it has been concluded that 1 in every 3 HIV patient and another in 1 in every 4 HIV patient may die. And there is a statistical prediction that in the coming years, 64% of HIV negative patients from tuberculosis, they will die. And all of the HIV positive patients will die. So that's me and all of you who will stand between this co-infection and the death. So that can only be prevented once we know how much is the burden of the disease. And WHO has simply given one solution of that when when you find that there is a TB HIV co-infection, treat both. Now, as a clinicians, we can predict on a first interview that what could be the fate of that patient. If your patient is HIV positive and with tuberculosis, then history will let you know that how delay is the diagnosis. Your first line investigation we usually do chest x-ray is a very good bedside investigation which let us know about the extent of the disease. So that will let you know how extensive is tuberculosis. CD4 count will let you know how much affected is patient's immune system. And obviously we get AFB sputum for every case, and positive cases are at high risk of mortality. And as I told you in previous slide, that all of the positive cases are at threat of dying. And you know well that latent tuberculosis is one form of tuberculosis which is clinically not active. But HIV is one of the risk factors which can convert that dormant stage of mycobacterium into active disease. And then they both will lead to catastrophes. Now, chest x-ray, you know that we can ask chest x-ray to get on the bedside. We can ask the patient to go to the department to get a chest x-ray. It's a very handy investigation and it gives us big diagnosis, and same is true for diagnosing and categorizing the extent of the disease in case of this co-infection. So this was also aim of this study which I conducted, that chest x-ray, which is available in no time once you receive the patient, can help us, and let's see that what is the pattern on the chest x-ray for such patients. You know, we all know well that in non-HIV tuberculosis, the middle lobe, the apical, and the posterior segment of the upper lobe, that is more involved. And while in HIV, lower lobe pulmonary findings, calcified granulomas with satellite nodules, and there is few studies which have shown that normal chest x-ray was the prevalent pattern. And there are few radiological features which will never help you to differentiate between HIV TB co-infection and alone tuberculosis. These are miliary tuberculosis, pleural effusion, pneumothorax, lung abscess, and hyperinflation. It can be in both types of tuberculosis. As I moved along the study, it was very evident that even the radiological findings, they also depends upon the CD4 count. The common things which I was in my previous slide was highlighting, they can be explained by in HIV antibody positive patients with normal CD4 count. But in those in which CD4 count was less than 150, they have typical of HIV TB co-infection findings on a plain chest x-ray. And you know well that miliary tuberculosis is more common with HLA-BW15, HLA-DRB1, and HLA-DQB1. And interleukin-4 ability to affect all receptors and macrophages activation is one of the key underlying process in these diseases. And once I will show you the data, you will agree with this point that in our area, although HIV-TB co-infection was there, but the patient does not seems to be having low CD4 count. So data was analyzed for cured or treated patients, and their chest X-ray, which was available with all of the patient, that was reviewed along with the mortality. And among 720 registered tuberculosis patients, 4 were found positive for HIV, which makes 0.55% of total tuberculosis patients. And the most common abnormality seen was bilateral hilar lymphadenopathy, which was calcified, and bilateral upper lobe involvement, isolated left upper lobe involvement, right hilar isolated calcified lymphadenopathy, bilateral upper lobe with right side lower lobe involvement, and left upper lobe with left lower lobe involvement. Now you see that they all are typical tuberculosis findings, even with HIV positivity. So this is the slide which is showing single patient predilection, and you see that 2 were smear positive, and there was a cavity. Now cavity formation always clinically gives you a clue that this patient CD4 count may be low. And you see that in one patient, it has multiple cavities in the upper and lower lobes, and he was sputum smear positive, and he was a high-risk patient. While reviewing mortality, 720 registered tuberculosis patients, HIV status was looked into, and it was seen that among 4 positive, the 2 were cured from tuberculosis and 2 died. And among 1 died had negative and other was positive. So incidence may be low, but that's again alarming that your mortality in 4 patients, half of them died. So where we stand? If we review data from previously from different centers of Pakistan, from Karachi, the AIDS control center, the percentage was 19.39%. A meta-analysis from Karachi showed 1.4%. From Balochistan, 30.7% and 36.5%. And another study from Karachi, Hyderabad, and Lahore, they also gave in percentage of 0.34%, and Lahoris, they won. So they had the 0 number. So my conclusion was that early diagnosis and retroviral therapy is absolutely mandatory. And HIV-TB co-infection chest X-ray in our patients is mimicking HIV cases with good CD4 count. And absence of atypical features signifies need to get serological tests for HIV. So even if they are low in number, we should be getting screened all of the TB patients. And definitely this approach will be more effective to implement the WHO standards for treating HIV and TB concomitantly when there is an infection. Thank you very much.